Okay, good morning, everyone, and welcome to the June Grand Rounds celebration. First, I'd like to acknowledge that we're on the traditional lands of the first people of Seattle, the Coast Salish people, and the land touches the shared waters of all tribes and bands within the Duwamish, Suquamish, Tulalip, and Muckleshoot nations. And we honor with gratitude the land itself and the Native American tribes and bands. I want to thank Nat Youngblood, who pointed out that we could make a more inclusive statement that includes many of the tribes in the region, and acknowledging that there is not unanimity among the tribes about exactly how, about some of the tribal issues. So we do want to be inclusive. We also want to affirm the commitment of Seattle Children's and of our psychiatry program in particular, of being aware of privilege and oppression and how they play a role in the lives of patients and employees, and that we are striving to be anti-racist and improve care for groups with less privilege. And we also belatedly celebrate that May was Asian Pacific Heritage Month, and that this spring, March 30th, 2022, is the 80th anniversary of the Washington State internment of Japanese American families. And the overall message is that we really want to be an anti-racist space and to condemn hate and racism. Also, belatedly, we want to celebrate that May has been Mental Health Awareness Month. And Ann Vanderstoop, and I'm sorry, I should have introduced myself. I'm Carol Rockhill, who along with Mendy Manhars co-coordinate the Grand Round series. Ann Vanderstoop, who was previously a co-coordinator of this rounds, shared with us this NAMI statement on the shootings in Uvalde and Buffalo, which we thought was very powerful and wanted to share with this group. Since some people may be on phones and not able to see this, I'm going to read it. Dear community, there are no words left to describe the depth and tragedy of the losses suffered in Uvalde and Buffalo massacres. Gun violence is a public health crisis. Racism is a public health crisis. We mourn with and stand in solidarity with all of those affected by these incalculable losses and those living with the trauma and the grief that come from the oppressive epidemics of gun violence and white supremacy. When our nation experiences a mass shooting, we look for answers and for something or someone to blame. Often these conversations turn to mental illness. Laying the blame for mass shootings on mental illness overlooks the violent and oppressive systems that contribute to allow such shootings to take place and directly harms and stigmatizes those living with mental health conditions. People with mental illness are more likely to be victims of violence rather than perpetrators of violence. As we advocate for mental health care for all, we stand against white supremacy and gun violence. We encourage you to learn more about mental illness, reach out to support systems, educate yourself on anti-racism, and use your voice. With that, I would like to, despite the violence and hate that has been happening lately in our nation, call out that today is a celebration day for our Child and Adolescent Psychiatry Fellows, and a culmination for the fellows who are presenting of their 2 years of fellowship. And I'd like to introduce Dr. Chris Barley, who has been in charge of the academic scholarly inquiry projects that they're presenting today.
Yep. Good morning, everyone. Yeah, this really is a celebration day, and it is the first of what we hope is an ongoing tradition of having the last ground rounds of the year be an opportunity for our fellows to show off what they have done. There's an ACGME in our program requirement for each of them to conduct a scholarly inquiry project. And as you will hear over the next hour and a half, they have done so, each with their own distinct signature. We ask them to get engaged in a topic about which they are passionate and to run with it. And today we'll have an opportunity to hear the various interests and activities in which the fellows have engaged. Each fellow is going to have about 15 minutes or so to tell you what they've done over the last couple of years. I'm going to hand it over to the first presenter, Gabrielle Curry, in one moment. And in kind, she will then move on to the next two presenters, Mac Jensen and Michelle Dick, who will be next. Mendy Manjares will be monitoring the chat, and that's where we would like you to submit any questions that you may have regarding their presentations, and we will take up the Q&A after all the presentations are over. With that, I'm going to introduce Dr. Gabrielle Curry, and she will introduce her project and tell us what she's done. Gabrielle, the stage is yours.
All right. Hi, guys. I'm Gabrielle, and let me just get my PowerPoint up here.
Gabrielle, would you mind if I broke in with things that I should have said when I had the floor?
Yeah, go for it.
Just a couple quick announcements. One is that this is the last grand rounds of the series, and the next grand rounds will be in October. That'll be our kickoff for the next season, and it will be in person at Wright Auditorium, we hope, as long as COVID allows, but also hybrid, so you could still attend the way you're attending today. I also wanted to alert people that this presentation is longer than usual and will be ending by 9:55 today, and that after this meeting, there will be a faculty meeting, but it's not until 10, and that the fellows will have their case conference at 11. So sorry about that. I should have said those things earlier.
No worries. All right. So as Dr. Barley said, my name is Gabrielle. I'm one of the second years. For anybody that knows me, I'm sure you're not shocked to see that I am talking about racial disparities. It's something I'm extremely passionate about. So my project is titled Implicit Bias Training Decreases Racial Disparity in Restraint Use on an Inpatient Psychiatric Unit. How do I go forward? Off to a solid start. There we go. All right, so I don't have any disclosures. Objectives for my talk today is I want everybody to just have a basic working definition for implicit bias as well as for adultification, to recognize just some of the effects of unchecked implicit bias so that we can all have a better idea about why this is so important. And then the last is to provide objective next steps, because this is something that is causing serious harm right now, and it's something that we need to actively and aggressively be working on so that we can decrease negative outcomes that our patients are experiencing and our staff is experiencing. So first off, implicit bias. The big thing about this is that it's unintentional and subconscious. Despite that, our unconscious attitudes influence our affect, they influence our behavior, they influence our cognition, and they have serious harmful impacts based on those things. So there have been studies that have shown that implicit bias is more strongly associated with inequitable health outcomes than explicit bias or explicit discrimination. So this is something that is harming a lot of people every year. Multiple studies have found an association between implicit bias and worse clinical outcomes. So next is adultification. So this is a form of racial bias, and it occurs most commonly towards BIPOC youth. And essentially what it is when children are perceived as older than they actually are. So that leads to them being held to developmentally inappropriate expectations in relation to their cognitive, emotional, behavioral capabilities. So a really clear example of how this might happen is there was I believe she was a 6-year-old girl named Kaya who went to school, and she had her, little sunglasses on that she loved. And when she came into class, her teacher asked her to take them off, and she didn't want to take them off. And that led to the police being called and Kaya being placed in handcuffs and put in the back of a police cruiser because she wouldn't take off her sunglasses. So these are the types of things that happen when children are viewed as more mature because it takes behavior that would otherwise be understood as this is, a 7-year-old being a 7-year-old to this is somebody who is much more developmentally mature than they are, and they're making these really terrible, horrible choices that need punishment and need to be punished aggressively. And this happens across settings. So this is happening in schools. This is happening in policing. This is happening in welfare. This is happening in hospitals. There are some very clear ways that this has happened in our own hospital as well. So I don't have time to share a ton of stories, but there have been some really horrifying things that have happened in our hospital due to adultification of our BIPOC youth, including a 10-year-old child being tackled not too long ago. So it's causing significant harm. So Marty kind of stated why I think this matters so much. The worst health outcomes include death. So there was one study from 1993 to 2018 that found 79 pediatric restraint-related deaths across settings. And if you've been on the PBMU, you know how frequently restraints are happening. So we are doing physical restraints every single day, multiple times a day. And they cause a ton of harm, not only for the patients, psychologically and emotionally, but there's also a lot of physical risks that are involved, including even potentially death. And then I think it kind of stands to reason that there are also worse provider-patient interaction and lower patient satisfaction when the provider has a lot of unchecked implicit bias. Nope. So physical restraints, this is the specific outcome that I focused my project on. And I chose physical restraints because they are dangerous. Like I already said, there was that study that found the 79 pediatric restraint-related deaths. They're also traumatic for staff. So we've heard some really moving stories from staff members who are involved in these restraints, and it's really just a emotionally draining experience, especially for our BIPOC staff, when they see restraints being used inequitably, or not inequitably, unequally. More on BIPOC kids than our white kids. So it's something that is really tough for the kids and also for the staff that are having to perform them. So there was another study that showed that staff responsible for restraining patients have increased risk of physical and psychological trauma, burnout, and staff turnover. So I just want to really emphasize that it is in everyone's best interest to decrease restraint use. And it's important to examine exactly who is getting restrained and why they're getting restrained, especially when you consider things like adultification. So are we seeing our Black patients as more mature than their peers and where they are at and should be at developmentally? Okay. So what are some of the strategies that can be used to mitigate our unconscious biases? So I really like this little picture. It has organizational level, individual level, and then both. So I'm not going to go through all of them, but my project specifically targeted meaningful diversity training. So I think we've all been to the like 1 hour 1980s video EDI training where there's some like really just egregious statements that are made, and then they do that like kind of robotic checking the person who made the statement, and it all resolves really happily. That may be the case sometimes, but that's definitely not the rule. And we need more meaningful training. We need training that can address a wide variety of people who are coming in with very different backgrounds and understandings in terms of bias and anti-racism and diversity. So we want trainings that can target a broader group of people and that are actually compelling and move the needle. All right, so now we get to my actual project. So because of a project that a previous fellow had worked really hard on, shout out to Callie Hobson, we knew that restraints were happening more frequently for our BIPOC kids. One thing that I get really frustrated by is I see a lot of projects showing all of the racial inequity, and then it's just kind of like, what do we do now? We know that there's this huge problem, but nobody's taken that next step to say, we're going to fix it by doing XYZ things. So when I was thinking about what projects I wanted to do, I knew that I wanted to focus on continuing the project that Callie had started. I was put in contact with this organization called Conscious Anti-Racism Training, and they had this really cool anti-racist, anti-bias training that they offered for large groups. So first thing we did was petition the hospital to say, we know there's a problem. This is something that we need to be putting a lot of funding into to, ensure that these issues are being addressed. The issue that we came up against first was that hospitals and organizations oftentimes won't fund things if there's not research showing that it's effective. So since this is something that hasn't been researched at all, we didn't have any of that data. We didn't have any of those numbers to say, here's a pretty chart for why this is important. But we could see the harm every day that was happening for our kids. So I was really determined to make this happen. So I used a grant that I got through SAMHSA, which is the Substance Abuse and Mental Health Services Administration. And I also just want to shout out Ravi here, because even once I had the grant money, there were multiple levels of barriers that we had to get through to actually allow them to let me use the grant money for this specific project. And I had to appeal twice, and Ravi came with me both times and really advocated for why this project was so important, because when I get really passionate, sometimes my words start getting more just tense. And so he was able to really help make sure that that this got pushed forward. So the project itself, over the course of a 2-month period, all staff members on the PBMU completed an 8-hour training regarding health equity and anti-racism. The training was called Conscious Anti-Racism, so that's this one right here. And the training was paid. They were allowed to do it on paid time. It was protected time. And they received continuing education credits for completing it. So There were components, including modules on mindfulness, recognizing and better understanding uncomfortable emotions about racism, cultivating compassion, improving communication, processing stress and bias, and setting healthy boundaries. Before they completed the training, we had everybody do the Harvard Implicit Association test and report their results. Then they did the training. After the training, they did the IAT again and self-reported their results. And then we measured the change. All right, I'm seeing that I am running out of time, so I'm gonna fly through this. Or try to fly through this. Our first hypothesis was that anti-bias training will lead to a decrease in implicit bias scores on the IAT, and it did. So it was statistically significant, and thank you so much to Alicia for being the one who analyzed all of this data and put it into ways that I could understand. And then our next hypothesis was that decreased implicit bias will be associated with decreased disparity in restraint use on the PBMU. And it was. So there was a statistically significant difference in the total number of restraints by racial and ethnic group and quarter. And a statistically significant decline in restraint use between Q2, which is when the training was given, and Q3, which was the first quarter after everybody had completed that training. So here are some charts, and because I am running out of time, I'm not going to be able to go all the way through it, but I just want to highlight, so this is Black or African American kids on the unit, and this is what percent of kids were restrained once during their admission. The darker color is the population. So in Q1, Black kids made up 6% of the population. And then the lighter color is the percent of restraints. So they have almost double the restraints. It's the same in Q2. And then if you look here at non-Hispanic white, they made up 56% of the population and 58% of the restraints in Q1. So you can see the really significant difference. Then when you get to Q3, when we completed our training, they made up 6.8% of the population and 7.9% of restraints. So that's a huge decrease from almost double the population to the restraint use to just slightly higher. And then unfortunately it did go back up in Q4. I'm getting messages to wrap up, so I don't have time to go through all of this. What does it mean? Anti-bias training can decrease bias. Decreased bias is associated with decreased harm. The reduction in harm was not sustained, so we need this to be ongoing. It can't be a once-a-year training, because that once-a-year training will last for about 3 months, and then there's going to be a spike right back up to the pre-training levels. So I have huge news. We got approved for ongoing booster trainings that are going to be occurring quarterly. We got funding from the hospital because we had these numbers that we could say, look, it works. Even though we knew it was important, now we can show with data that it works. So yeah, I don't have time to say a ton more, but thank you to my whole team that made this possible. Robbie, Alicia, Shannon, Avery, and Connor. I appreciate you guys so much. And thank you for letting me go a couple minutes over. Stop sharing. So next is Dr. Michelle Dick and Dr. McMichael Jensen.
Hi, everyone. Are you able to see my slides? Yes. Okay, great. I'm going to get started right away then. Hi, everyone. My name is Mac Jensen. I'm joined by Michelle Dick. We are both finishing our second year of Child and Adolescent Psychiatry Fellowship. Over the last 6 months, we've both participated in the Program Directors in Patient Safety and Quality Improvement Educators Network. And we're going to both be discussing our experiences with that program, our experiences working on patient safety and quality improvement projects during fellowship, and our goals for the future of the curriculum of the fellowship in and around this area. Dr. Chow has been our supervising mentor for this project. So going on to disclosures, we have no disclosures at this time. So these are the objectives that we would like to cover today. One, to explore the need in and around the gap between clinical learning environment and the GME milestones related to fellow participation in QI and patient safety projects. To explore the journey that either of us have taken to get to the point of participating in the Pdpq. And we'll describe more of what the Pdpq is, the Program Directors in Patient Safety and Quality Improvement Educators Network. We'll also describe Project ECHO as a means for facilitation of that, and describe some of the future directions that we have worked on for the fellowship. So let's start by looking at the needs in the clinical learning environment. So CLEAR, or the CLER, it was started by the Acgme in 2012, and the goal was to give feedback to improve patient care through optimization of the clinical learning environment. So they've collected all this data through site visits and surveys, and they use that data to compile a list of themes that they've noticed. The areas that they focus on are patient safety, healthcare quality, including healthcare disparities, care transitions, supervision, fatigue management, mitigation, and duty hours, as well as professionalism. The first report came out in 2016, then another one in 2018, and the most recent one in 2021. In the original report, there was concerning data around patient safety and healthcare improvement, which led to efforts to correct this deficit. So going on, here are some statistics from the latest report around specifically patient safety. So this is from the 2021 report, and these numbers have improved greatly since the 2016 report came out. So they report that 97% of participants or trainees report that the clinical environment is safe to report errors. However, they report that generally trainees had a lack of understanding about where and what they could report, including what defines a near miss or a close call. 74% experienced a safety event, and 54% of those did report it themselves. 88% of the trainees have limited knowledge of patient safety principles and methods. These are things such as fishbone diagrams, root cause analysis, Swiss cheese model of systems failure. 40% of PGY3 or higher reported being involved in an interprofessional investigation of a safety event that included analysis, development of an action plan, and monitoring for improvement. So here are some statistics on the quality improvement section from the report. 75% of trainees reported knowing their clinical environment's priorities for improving healthcare quality. 62% had limited understanding of QI terminology and methods, such as Lean, Plan, Do, Study, Act, cycles, and Six Sigma. 79% of them had participated in a QI project designed by them or their program. However, only 47% reported that their QI project was directly related or linked to, to a clinical learning environment goal. So CLEAR takes all this data and they formulate these themes to kind of address areas for improvement. In the past, QI and patient safety were some of the largest areas for improvement coming out of CLEAR. However, over the years, there were definite improvements noted. And in the 2021 report, the theme 2 was around QI and patient safety, especially pertaining to healthcare disparities. In the past, I believe this was the first theme or the top theme that they wanted to address. So further in the report, they go on to discuss a few different things, that there continues to be a disconnect between the GME milestones and the priorities of the clinical learning environment. And this difference can be seen by comparing single event-based learning rather than longitudinal competency-based approaches to teach this. And trainees will only complete usually the first couple steps of a PDSA cycle. And overall, they identified a lack of investment in creating faculty to foster this or fostering this in faculty. So this is a slide from the Pdpq, and it's comparing the development of competency from two different perspectives, specifically the clinical learning environment, which is the thin blue line, and the GME, which is the dark blue line. You can see there's a gap between the way that the GME milestones are set up around QI and patient safety and the needs of the clinical learning environment. So the GME milestones are set up in a way to allow competency to be attained later in training than what is required by the needs of the clinical learning environment. So the goal would be to have these two trajectories kind of align and have the GME milestone development path kind of shift to the left and upwards as well, as indicated by the green arrows. And this would allow trainees to attain early competency and basic leadership skills in patient safety and QI to better meet the needs of the clinical learning environment. So how is this gap being addressed? One of the ways to address this discrepancy was the formulation of the Pdpq, which is a long title of the Program Directors in Patient Safety and Quality Improvement Educators Network. So it was created in 2019 in response to this data from the CLEAR report, which we talked about earlier, showing the need for improvement in quality and patient safety, improvement in patient safety education. It was designed to create a learning network for directors and faculty to design and disperse curriculum around patient safety and QI. So my QI and patient safety journey to participate in this program started with a QI project of my own of updating the call manual, which we're going to discuss a bit more later on. The contributing author to a book chapter on QI and patient safety in graduate medical education. I'm going to briefly describe my work on the book chapter now. So as I started to discuss my call manual project with Dr. Shao, he became my project mentor for the project, and we kind of shifted it from an individual work to more of a group project, and he invited me to collaborate as an author on this book chapter he was working on. The chapter that we collaborated on was called Managing the Culture and Teaching of Patient Safety and Quality Improvement in Psychiatry Residency Training. It's in the book titled Graduate Medical Education in Psychiatry, and it will be published next month. So our section focused on getting residents and fellows involved in quality improvement and patient safety projects, and more specifically on strategies for small or newer programs. Given this, we tried to focus on small projects with large visible impact and advertising those projects so there's awareness and hype in these programs to get others excited and to see the benefits of these interventions in action. We had sections focusing on like the PDSA cycle, the lean model, and the Six Sigma principles. And this led Dr. Shao to invite Michelle and I to join the Pdpq program and to help develop us as leaders in this area and develop novel strategies for the future of our program around this area as well. So now I'm going to turn it over to Michelle to talk a bit about the Pdpq program, its structure, and how we participated in it.
All right, so like Mac explained, Dr. Shao had invited both of us to participate with him in Pdpq back in December, and we started this in January. So I'd like to talk a little bit about what Pdpq is a bit more. It's essentially a collaborative program between multiple organizations that include places like the University of New Mexico Health Sciences, Project ECHO, which is the extension for community healthcare outcomes, which we'll cover in a little bit, and then also the Acgme. And we're currently in our third cohort going through this program, and psychiatry is in its second year. And as time has gone on, more specialties have been added. Next slide, please. So Pdpq is a social learning network with specialty-specific and interprofessional or interdisciplinary collaboration. It provides opportunities for us to share and learn from other programs to enhance the current quality improvement in patient safety or QIPS programming that we have in place right now for our trainees, and also to provide an important overview of concepts like stakeholder analysis, assessment of learners, assessing the curriculum in the program, and also faculty development. It's not a place where we learned basic principles of QIPS, and although it does focus on building a program and enhancing a program, it didn't cover in-depth curriculum development. Next slide, please. And there's a number of guiding principles to the Pdpq program, and it's essential to notice that patient care and the clinical learning environment are central to this whole process. So the first main concept is that patient care benefits when trainees are fully integrated into their institution or department's QIPS initiatives. To achieve this, programs need to partner with institutional initiatives that are happening in the clinical learning environment, and that residents must acquire these competencies through meaningful work in the clinical learning environment, and that they develop excellence in these competencies along a continuum over the course of their training. Next slide. So now I'd like to talk a little bit more about our experience as psychiatrists in the program and how our groups worked. So each specialty has multiple teams there was a psychiatry small group that was co-led by Dr. Jacqueline Hobbs from the University of Florida and Dr. Ray Shao from the University of Washington. And there were a total of 6 teams participating for psychiatry that represented different training programs from across the country. Next slide. And so this was a 6-month-long program that consisted of weekly 1-hour sessions where all the participants from across the country and different specialties participated. They were broken up into small groups by specialty. So psychiatry would meet with all the psychiatry programs, and the same thing for internal medicine, et cetera. And then once we met as small groups, we would return to the large group for a theory burst where we would cover the new material or new concepts. And then in between sessions, we would complete inter-session assignments, which would build on the material or the concepts from the theory burst, and then also help us create a blueprint for our quality improvement and patient safety program enhancement. So our team, which consisted of Dr. Shao, Mac, and myself, would meet for 30 minutes every week in addition to go over this planning and review the work that we had completed to prepare to share it with the rest of the psychiatry programs. Next slide. So you can see here a very simplified or abbreviated example of what an assignment might look like. So this is just a partially filled out one just for simplicity for the presentation. But essentially we would complete assignments like this and fill out a lot of charts and mapping over the course of our participation in this program. And critical assignments are key things that we would complete and come back to time and time again, were things like mapping out longitudinal learning experiences, completing stakeholder analyses, creating systems of evaluation for the learners, and also systems to evaluate the program itself, and then also finding ways to identify and develop key faculty leaders. Next slide. And then in addition to our typical sessions with the small groups and the theory bursts, we also would have some demonstrations of how different medical specialty groups were utilizing what we call the ECHO model to further develop their quality improvement and patient safety program. So for example, the psychiatry participants actually continued to meet monthly to do an ECHO session. So Project ECHO is a telementoring method that's used to create a community of practice to better leverage scarce resources. And it was originally developed in New Mexico to help improve access to specialized care by hepatologists in areas where there was little access to these specialists. And so they achieved this by educating and improving the ability of local clinicians to provide this more specialized care through sharing best practices to reduce disparities, gathering and monitoring the outcome data from these communities, and then also using case-based learning to share information across participants. Next slide. So ECHO sessions are built on what we call the hub and spokes model, with the experts or specialists at the center, and then every individual community provider represents a spoke on the wheel. So there isn't a top-down approach to this, and it's created in a way so that exchange of information can occur in all directions. The community providers can share and learn from each other, the experts learn from the community, and vice versa. So things are happening in all directions, and specialists are able to learn and create best practices from the information they're gathering from these communities. So if you take this model and apply it to Pdpq, and how it relates to QIPS work, we can imagine that the patient is the medical trainees. The providers in the community essentially represent the program directors or the other faculty that are in charge of developing quality improvement and patient safety curriculum. And the community is Pdpq, and the experts or the hub of this wheel are people from the Acgme teaching this, and people like Dr. Hobbs and Dr. Shao, who teach the material and also co-lead these small groups. Next slide.
Now I'm going to kind of jump back in, and we're going to move to discuss more of the current and future directions for our program in the realm of patient safety and quality improvement. First, I wanted to start with a project that was initially my individual work and the efforts that were done to make it a fellowship-wide project. So it'll be discussing the project I was mentioning earlier about the call manual. So first, I wanted to start off to just go over briefly a little bit about call for the fellows at Seattle Children's. It starts at 5 p.m., goes to 8 a.m. the next day after completing a normal work day. While on call, we cover the PBMU and the emergency consults in and outside the hospital, and also accept admissions to the PBMU. This often has many medical and psychological issues that come up through the night, from patients having cross-contamination of each other's blood, to broken bones, strangulation attempts, insomnia, anxiety, feeding tubes, medical and violent restraints, and patients and families leaving or wanting to leave AMA or leaving AMA. So there is a need for a centralized source of information. Fellows, when starting, are just being introduced to this totally new environment, this new medical record system, administration, and style of the hospital. And some of us will go 9 months before rotating on the PBMU inpatient rotation, and we all start covering it after about 1 month. When we start, we do have a buddy call where we work with a fellow a year above us to help you kind of learn the system, and we have 2 of those that happen at the beginning of the year. We also have attending on call as backup in case anything is needed, or to go over any sort of questions that do come up. So given the large variety of issues that come up, there needs to be a central source of information and kind of a reference guide or checklist. So there was a call manual in the past, and there was an update that needed to be done. No one person had really kind of championed to keeping it up to date. And during my first year of fellowship, I learned the Cerner EMR, and then after about 4 months, we switched to the new Epic electronic medical system. So at the start of the fellowship, there was a push to have all of us kind of edit the call manual. However, there were not a lot of large changes being made. It was bulky. And further, with this switch to Epic, it required a large overhaul to facilitate the idea of people in a group making small minor edits while using it. So the task was to make a bunch of Epic checklists for common scenarios that kind of come up on call overnight. I worked on making these changes for the overnight and weekend call while I was working on those services. Also, when I was working in the continuity clinic and the CL service, also made guides and changes during those times. I distributed to my colleagues when I made them, and they were then added and compiled in the call manual with the assistance of the chiefs. And this was in time for the arrival of the new F1 class, who was about to become the F2 class. So with the document having the large update to kind of cover the new EMR, the barrier for everyone to be an author is lowered. And the intention now is for this to be more of a collaborative, dynamic document. And that was expressed to everyone at the beginning of this year. And we tried to encourage everyone to add solutions to problems kind of as they come up or arise. And Towards the beginning of the academic year, there was some editing of the document with different fellows contributing. This was likely prompted by the use of the document by the new fellows on call and their utilization of it and finding it helpful. But as the year's kind of gone on, there's been less and less updating of the document. We've tried to kind of engage or attempt to engage the progress with emails from time to time, highlighting some of the changes that we've noticed in the document and acknowledging those who contributed changes. And the hope we kind of have for the future is that the document continues to be used in this dynamic fashion over the years to come and continues to be a large benefit to the upcoming fellows to deliver safe and efficient care for the future. I'm going to now turn it back over to Michelle, who's going to talk about some other future directions for our program.
So Mac was talking a bit about his individual scholarly inquiry project that he completed in addition to doing this. I'd also like to acknowledge that I had another individual scholarly inquiry project that I completed, mentored by Dr. Simmons, to develop a curriculum to complete the PGY2 curriculum for the general residents who rotate through our child and adolescent psychiatry clinics and unit. And so actually, although it wasn't directly related, that project helped me develop a lot of skills in needs assessment and curriculum evaluation that I did use when coming up with these ideas and completing the Pdpq program. So in addition to improving our current work, as Mac was talking about, participation in this program allowed us to identify a number of key concepts that we'd like to focus on when we work towards improving our quality improvement and patient safety program here at UW. In Seattle Children's. So first off and foremost, we believe that quality improvement and patient safety work should be equity, diversity, and inclusion work. Given our hospital and our department's current efforts and goals, there's a huge need in our clinical learning environment, and our fellows have a very strong passion for this work, as you can see from what Dr. Curry just presented. And we can utilize our skills and partner with the clinical learning environment to meet this need and merge the patients and the community's needs with our education, which, as we've talked about already, is really the best way to learn and to build these competencies in quality improvement and patient safety. Also, during our small group discussions in Pdpq, it became apparent that as psychiatrists, we're in this unique position of having a very rich interprofessional and interdisciplinary environment. We partner with therapists on a daily basis, nurses, social workers, case management, and we work with different medical specialties like adolescent medicine and peds to create best outcomes for things like eating disorder treatment, different pathways in the PDMU, and develop multidisciplinary treatment programs like the DBT team. So to best combine our educational program with our clinical learning environment, we should be focused on utilizing these natural collaboration opportunities and merging those for educational benefit in our QIPS initiatives. And then another area was building leadership opportunities for fellows in quality improvement and patient safety. And we'll talk a little more detail in a minute about that. And then last thing was that if we can find ways to improve what our program already has available in institutions, we can utilize, integrate, and engage fellows with those resources and also improve using what we already have. Next slide, please. So utilizing current resources would include things like increasing participation and engagement of fellows in things like safety huddles, which are already happening on a daily basis, and also utilizing resources that are already available, created, and free, like the Institute for Healthcare Improvement modules. These modules are usually introduced in the second year at present in our fellowship, and we feel that we can move these earlier on into first year, maybe even in the first half or orientation, to really bring up the development of those QIPS competencies earlier on to meet the needs of our clinical environment. There's also a lot of programs like Fellows College at Seattle Children's and in the House Staff Quality and Safety Committee that are rarely utilized by our fellows, be it because of time constraints or lack of awareness. So we believe that we should be working to improve access and awareness of these to make fellows aware and engaged in what these different institutions that we partner with and are part of do. Also, Seattle Children's has this rich tradition of utilizing the Toyota Lean Management System. And in the past, this was a more uniform component of all employees' orientation, but current trainees haven't had as much training in this during their orientation as in the past. So we feel that this could be an excellent opportunity to start quality improvement training early on that's already embedded in the culture of Seattle Children's. and would again merge the clinical learning environment with our education and be a meaningful partnership. And then finally, e-feedback. We've been getting a lot of notifications in different emails that the numbers of these submissions are down, and they want to bring them up. And we also feel that this would be an excellent way to introduce fellows to identifying, assessing, and analyzing safety events and areas for quality improvement, especially on an interdisciplinary level, because areas that some fellows might have submitted this for in the past include things like transferring from different units or transferring from different services. So this is an area that's also has a lot of benefit or opportunity for interprofessional and interdisciplinary collaboration. And we're hoping that we can promote submissions and orient fellows to this process earlier on and incentivize them or get them engaged in submitting them. Next slide. So then in terms of developing leadership opportunities, this can be another way to really build engagement for our fellows, both through participation and the leadership in the safety huddles. And then also we're talking about building a quality improvement and patient safety representative position for each fellow class. So there'd be 2 per year. So tasks for these representatives could include things like representing the University of Washington's House Staff Quality and Safety Committee and being a part of that, leading a quality improvement and patient safety business meeting, which I'll talk about in just a bit. And then also being responsible or participating in disseminating information from important meetings and other institutional programs and disseminating that information to the rest of the fellowship. Next slide. So finally, I'd like to talk about our business meetings. So this is something that the fellows engage in multiple times a month, and we use this Friday around lunchtime to meet together as a program, the fellows and Dr. Shao, to talk about important upcoming events, discuss issues, and a bunch of other business aspects of the fellowship. So we've already started utilizing these to further our quality improvement and patient safety programming. And this has already included doing things like participating in the Washington State Medical Association's Health Equity, Morbidity, and Mortality program, and trying to encourage fellows to participate in this. And so we want to take this even further by creating an additional business meeting once a month on the months where there isn't that M&M to review potentially key principles of QIPS, discuss cases, get updates from the quality improvement and patient safety representatives from things like the Fellows College or the House Staff Quality and Safety Committee. So it can serve as another opportunity for leadership, and then also an opportunity to practice these skills, to demonstrate a knowledge of these skills and such. Next slide. So it sounds like we will be saving questions for the end, but Mac and I wanted to take a moment to thank Dr. Shao for inviting us to participate in Pdpq, to serve as our mentor, as well as for mentoring Mac on his individual scholarly inquiry project. And I'd also like to thank Dr. Simmons for her mentorship on my individual project on curriculum development. Thank you.
I think now we'll pass it on to Bridget Mcnulty. Dr. McNulty, I'm not sure that we have sound from you. We can see your slides, but if you had started talking, we did not have sound.
You hear me now?
Yes, yep.
Okay. Sorry about that, everyone.
No worries.
All right, and you can see my slides, I assume?
Yep, now we can see and hear you. Thank you.
Oh, perfect. Okay. So hi, everyone. I'm Bridget Mcnulty. I'm one of the second year fellows, and I had a lot of projects that I was working on over the last couple of years, and I had to kind of pick one to do this presentation on, and this is one that I felt was pretty interesting. And so I just wanted to share some information about the intersection between inflammation and mental health in child and adolescent populations. This is stuff that I've been working on as part of a scoping review that I'm in the process of writing, and as part of a grant that I'm applying for further research in this field. So first of all, I have no disclosures to discuss today. Some learning objectives for my portion of today's talk include providing an updated review of the available evidence regarding the relationship between inflammation and psychopathology in children and adolescents. Second, to recognize the limitations of current research methodology, including a lack of diversity among study subject selections. And thirdly, to discuss future directions for research, including a project with a focus on the effects of race and adverse life events on inflammation and mental health. So I'll start with an introduction of why inflammation and mental health are so important to look at, go into the methods of behind how I've been conducting the scoping review, and to give a presentation and discussion of evidence by psychiatric condition. And then I will end by discussing further directions in research, including the project that I'm currently writing a grant for, and just some conclusions. So first of all, the introduction between inflammation and psychiatric illness has become increasingly of interest to the scientific community over the past 3 decades. Thousands of papers have been published on this topic. Inflammation has been proven through decades of research to be associated with chronic medical illness. And it has been well established that chronic medical illness is also highly comorbid with psychiatric illness, including those with a juvenile onset. So for example, lots of studies have shown that children with asthma early on in life oftentimes are at higher risk of developing schizophrenia. Early life stress has also been well documented to be associated with increased inflammation. So what is inflammation? I'm going to keep it pretty basic due to lack of time, but at very basic level, inflammation is a complex reaction to noxious stimuli that involves the release of several downstream effects, including pro-inflammatory cytokines, chemokines, acute phase reactants such as CRP or C-reactive protein, and adhesion molecules. It also involves a downstream effects of these molecules to vascular response and activation and migration of the immune system, including leukocytes. In the interest of time, I'm just limiting my discussion to 2 particular cytokines and acute phase reactants that have been well established in the literature to be associated with inflammation and mental health. The first being IL-6 and the second being C-reactive protein. So C-reactive protein is actually a downstream effector of IL-6, and when IL-6 cascades, it affects a multitude of areas within the body, inducing a cascade of inflammatory markers. So IL-6 levels will go up and induce higher levels of TGF-beta, induce neutrophil accumulation, immunocomplex deposition, activate macrophages and neutrophils, and even induce bone resorption through osteoclasts. This is just a very simple diagram. Obviously, the effects are much more complicated, but just to give you an idea of how important this particular cytokine is in moderating or in mediating downstream effects of inflammation. So what is the link between inflammation and psychiatric illness? The very strongest evidence appears to be involving adults with major depressive disorder, bipolar disorder, and schizophrenia. For example, it's well documented that there are higher levels of IL-6 and TNF-alpha, tumor necrosis factor alpha, in depressed patients in adult populations. It's also been shown that INF-alpha in HCV in hepatitis C treatment consistently induces depressive symptoms in both children and adults. And many studies have actually assessed the utility of using anti-inflammatory medications such as NSAIDs, omega-3 fatty acids, and TNF-alpha in the treatment of psychiatric illness. Cytokine production definitely differs between children and adults, and it is of note that cytokine production has not yet been categorized over the course of normal development in child and adolescent populations. The other thing to note here is that the majority of studies involve adult populations, and the last systemic review involving pro-inflammatory cytokines and psychiatric illness in child and adolescent populations was in 2014, and before that there was only one other review. Therefore, the objective of my talk today is to provide an updated scoping review of the literature on inflammation and psychiatric illness in children and adults. So the methodology I used was using the PRISMA method of conducting a systematic review. I chose to use PubMed and Embase as my two databases to draw information from, as well as, of course, doing manual searches and referencing bibliographies. I determined mesh key terms and keywords using the PICO method. And this is just an example of some of the keywords that I use: neurogenic inflammation, mental disease, child and adolescent populations. And through this process, I identified a number of studies that should be included in the review. And this is just a standard PRISMA flow sheet. So I actually started out with a number of papers, around 3,000, ended up screening those records, excluded a great deal of them for things such as my exclusion criteria. So my inclusion criteria included studies that have been published 2014 and later, as this is as there was already a review that was done on this topic in 2014. I limited studies to birth to 18 years old. I did not include maternal immune activation, although that is part of my introduction and discussion. I only included English articles and articles where a full text was available, and I limited my discussion, or limited my review, to human subjects rather than include animal models. Studies were included as long as they measured pro-inflammatory cytokines in child and adolescent populations with psychiatric disease. And I will just say that this review is quite limited using the PRISMA method because I did not include another reviewer. It was, all these papers were reviewed by myself. Usually there's at least 2 reviewers to reach consensus on which papers should be included. Studies involving autoencephalitis, PANS, PANDAS, or congenital developmental disorders such as Down syndrome or Prader-Willi syndrome were excluded just because they were beyond the scope of this particular review. Other psychiatric diagnoses addressed in the scoping review include ADHD, OCD, anxiety, and autism disorder. However, for the sake of time today, I've limited my data sets that I will be presenting to major depressive disorder, bipolar disorder, and psychotic illness. So we'll start with major depressive disorder, other depressive disorders, and suicide risk. So there were 4 papers, or not 4, sorry, there were 6 papers that I identified that were published since 2014 that were of relevance using my inclusion criteria. The first was a paper done in 2014 by Kondaker et al., which looked at the association of serum IL-6 and C-reactive protein in childhood with depression and psychosis in later adult life. This was a population-based longitudinal study, and what it showed is that IL-6 at age 9 was positively correlated with increased risk of depression developing at age 18, but CRP was not associated with any psychiatric outcomes. I also want to draw attention to the fact that I've noted that whether race or ethnicity or socioeconomic status has been included as a consideration in this data point, and in this case, they either designated people as white or not. The next study that I saw that was relevant to this topic was Belim da Silva et al. In 2017, which looked at the connection between inflammation and internalizing disorders, including depression in adolescents. And what they found is that there were increased IL-6 levels overall, but there were no difference in IL-10 levels, which is an anti-inflammatory downstream effector. The next was Audi et al. In 2018 that looked at dietary patterns, body mass index, and inflammation in their relationship to the depression. And what they found is BMI at age 14 was positively correlated with BMI, leptin, C-reactive protein, and depressive symptoms at age 17. And that a Western diet was correlated with increased risk of depressive symptoms in adolescents, and through BMI correlated with increased inflammatory markers, including serum adiponectin and C-reactive protein. Peters et al. Looked at interleukin-6 and depressive symptoms, as well as affective perception in male and female depressed adolescents in 2018, and overall found that there were increased IL-6 levels versus controls, but there were no difference between groups and other cytokines that have been implicated in inflammation and mental illness, including IL-1 beta and TNF-alpha. However, TNF-alpha was positively correlated with self-report of somatic symptoms. Jaha et al. In 2020 actually looked at suicidal behavior in young adults and adolescents. And what they found was that only IL-4 levels differed among three groups. IL-4 was negatively correlated with suicidal behavior when compared to controls. And then IL-4 was also negatively correlated with depression severity in these patients. And then Zakowska in 2022 is the most recent study that I found pertaining to this topic, looking at cortisol and the development of depression in adolescence and young adulthood. And what they found after looking at a variety of reviews and doing a meta-analysis was that elevated morning and nocturnal cortisol levels are risk factors for the development of depression, but not necessarily biomarkers for active major depressive disorder. Okay, and then moving on to bipolar disorder. Less studies were found regarding this disorder that met criteria for my inclusion. A lot of studies in bipolar disorder take a look at young adult populations that are over the age of 18 up to 27. So that is why the number of studies here is a lot less than those included for major depressive disorder. The first year is Ramani at 2021. Who was looking at pro to anti-inflammatory ratios and whether they were connected to reduced cognitive flexibility in symptomatic adolescents with bipolar disorder. And what they found is that C-reactive protein was positively associated with a bipolar diagnosis, but other cytokines that they looked at were not significantly different from controls. They did find that lower IL-6 to IL-10 and CRP to IL-10 ratios were associated with lower neurocognitive flexibility in symptomatic bipolar disorder. So basically, higher levels of IL-6 to lower levels of IL-10, which is an anti-inflammatory cytokine. Petrov in 2018 looked at bipolar disorder in youth and the association with vitamin D binding protein, which is well established in the literature to be associated with inflammation. And what they also looked at serum IL-6, NFK beta, and autoantibodies to oxidative stress byproducts and vitamin D binding protein. And what they found is that IL-6, NFK beta, and all the rest of those things were not significantly different from controls, but that vitamin D binding protein was elevated in bipolar disorder patients versus controls, and suggests that vitamin D is part of the inflammatory process behind the development of bipolar disorder. Barsman in 2014 looked at correlations of inflammatory gene pathways and aggression in pediatric bipolar disorder, and they specifically focused on serum TNF-alpha gene expression, which was positively associated with aggressive behavior in adolescents with bipolar disorder. And then moving on to psychosis, a few more studies here. The first is the same study by Kondaker in 2014 that looked at major depressive disorder, also looked at psychotic episodes in the same population, and found that IL-6 at age 9 was positively correlated with an increased risk of psychotic illness at age 18. They did another study looking at atopic disorders such as asthma and so forth, looking at the association with psychotic illness, And what they found is there was no real association between IL-6 and CRP with psychosis. The next study here, Delaney, is that IL-6 and CRP was elevated in psychosis. And then Kondacher did another one in 2021 showing that CRP was associated with anhedonia and avolition in psychotic patients, but not necessarily asociality, and that high CRP was actually associated with auditory hallucinations. So future directions that were revealed by this review is that there's a number of studies that report elevated concentrations of inflammatory markers in this population. However, the temporality and specificity of this association remain unclear, specifically because there hasn't been a categorization of these markers in child and adolescents across normal development. And just a note regarding diversity and inclusion in research populations, as you could see from my tables, there really wasn't a lot of data regarding the racial backgrounds or socioeconomic status beyond white versus non-white, if there was data at all. And so future directions for research should also include effects of racial, ethnic, and lower socioeconomic background on inflammatory marker profiles. So the aims of my particular research focus is to categorize common inflammatory marker profiles throughout normal child and adolescent development, and by doing this, to build a database of demographic and medical background information for each participant, with the goal of looking at the relationship between inflammatory marker profiles and psychopathology, with an emphasis on racial, ethnic, and socioeconomic backgrounds. Just want to acknowledge, make some acknowledgements. Thanks to the whole program for being so supportive this year. Thank you in particular to Dr. McStork, Dr. Barley, and Dr. McClellan for helping me out with kind of thinking through this project and going through my grant proposal and that sort of thing. And thank you to my classmates, of course, for being awesome second year fellows. Okay, and now I'll pass it on to our next presenter.
Right, I believe that's me.
It is you. Yep, go ahead.
All right, can you both see and hear me simultaneously? Okay, great. So my name is Evan Taniguchi, and my project is titled A Retrospective Chart Review of Psychotropic Prescribing Patterns and Polypharmacy Rates for Youth with Autism Spectrum Disorder. I realize that's a mouthful, and hopefully we'll kind of break this down as the presentation goes on. Before I get started, however, just wanted to send a few acknowledgements. Dr. Sue Kim, who served as my mentor, primary mentor on this project for the past couple of years, Dr. Carrie Conan, who also provided really essential guidance and input, and Kylie Keller, who did the data extraction that was necessary for this project. So thank you to everyone who's here. All right, so before I get started talking about my project, I just like to give a little bit of introduction and background information on why I found this project important, and some information, or I should say a review of the literature surrounding prescribing patterns and polypharmacy rates in youth with autism spectrum disorder. So first of all, the core symptoms of autism include social communication deficits, restricted interests, and repetitive behaviors. While there's no treatment for these core symptoms of autism, the FDA has approved risperidone and aripiprazole for irritability, including symptoms of aggression. But despite this pretty limited set of approved medications and indications, there have been increasing rates of psychotropic use and psychotropic polypharmacy amongst youth with ASD, especially if other treatments may not be available or accessible. And these definitions will become important. While the definitions of polypharmacy and what we'll call multi-class polypharmacy can vary, just want to provide a general idea for those who might be unfamiliar with these terms about what I mean by polypharmacy and multi-class polypharmacy going forward. So generally speaking, again, the use of 2 or more medications concurrently can be considered polypharmacy, and the concurrent use of 2 or more different classes of medication, such as maybe antidepressants or antipsychotics, for the purposes of this discussion, could be considered multi-class polypharmacy. Again, the definitions will vary, which we'll talk about. Estimates of psychotropic use in general have generally ranged from about 27 to 83% with psychotropic polypharmacy, in youth with autism spectrum disorder, ranging from about 35 to 54%, so pretty wide ranges. This variability may be at least somewhat attributable to the inconsistent operational definitions used in a lot of the studies that have taken a look at both psychotropic polypharmacy, or abbreviated as PP here, and multi-class polypharmacy, MPP, across studies. Many studies have also taken a look at clinic-based prescribing practices. A lot of the studies that have been done have looked at insurance-based claims data. Studies that have been done on prescribing patterns in clinic settings have shown that there can be pretty large, again, variations in prescribing psychotropic medications to children with ASD. In terms of demographic influences on prescribing patterns, the existing literature has pretty inconsistently described the effect of demographic factors, particularly race and ethnicity, on prescribing patterns for youth with ASD. And when other demographic factors have been examined, there appears to be pretty, again, significant variability in their effects on prescribing patterns in general. I also just wanted to briefly touch on the impact of COVID here. Since the COVID-19 pandemic, there have been, as we all probably experienced, an observed rise in the rates of children reporting new onset mental health concerns. And children with ASD may be particularly affected by this, especially when we consider how this might affect or might disrupt daily routines and lack of access to resources, including access to school, etc. So therefore, just want to outline some of my project objectives. Number one, we want to analyze prescribing patterns of the Seattle Children's Autism Center, a tertiary care center. Again, a clinical setting, instead of looking at insurance data, to look at prescribing patterns. We want to describe how demographic factors might influence prescribing patterns and polypharmacy and multi-class polypharmacy rates. We want to evaluate if psychotropic medication prescribing patterns were affected by the COVID-19 pandemic, including if there were more rates of certain class prescriptions, such as antipsychotics, during the COVID-19 pandemic. All right, so a very brief overview of our data extraction. Again, this was thanks to Kylie Keller, so thank you very much. The present study provides a retrospective review of electronic health records of patients seen at the Seattle Children's Autism Center. The patients seen in 2019 were generally considered our pre-pandemic sample, and the patients seen in 2020 were considered as our post-pandemic sample, or I should say our pandemic sample. Our participants, I included our inclusion and exclusion criteria here. Just an overview of our inclusion criteria. So the folks that we took a look at had to be between the ages of 3 and 21 years old. They had to have a diagnosis of autism spectrum disorder, and they had to be seen for psychiatric medication management or evaluation at the Autism Center, and seen by either a psychiatrist or advanced psychiatric advanced nurse practitioner. And they had to be seen somewhere between January 1st, 2019 and December 31st, 2020. These are some examples of the medications that we took a look at or examined during our study. And I classified them into 6 different categories using indication-based classifications. So ADHD medications, antidepressants, mood stabilizers, anxiolytics, hypnotics, and antipsychotics. We also excluded a number of medications, including over-the-counter medications, which, as you probably know, are not often prescribed. These would include things like melatonin or Benadryl, for example. We also excluded medications that were used to address the side effects of psychotropic medications. These might be things like benztropine. Medications with the same active pharmaceutical ingredient were also considered the same medication. So different methylphenidate preparations, for example, were considered as all methylphenidate. Different valproic acid or Depakote preparations were considered as Depakote or valproic acid. All right, so our definitions of polypharmacy and multi-class polypharmacy are included here. Psychotropic polypharmacy was defined as 2 or more unique psychotropic medications prescribed in each calendar year. And multi-class psychotropic polypharmacy was considered as 2 or more psychotropic medication classes prescribed in each calendar year. The time of overlap for the purposes of this study were not considered. So a brief overview of our statistical analysis without getting too much into the weeds. We use descriptive statistics to describe characteristics of our clinical sample. We use chi-squared statistics to examine the difference in clinical characteristics between sample groups. And we use the binary logistic regression to examine the effects of demographic factors on the likelihood of polypharmacy. All right, so I'm going to give an overview of the numbers. Would like you to pay attention to a few key elements. So this is the clinical characteristics of all patients seen in both 2019 and 2020, including duplicate patients who might have been seen in both years. So in 2019, we saw a total of 851 patients that were included in our study. And in 2020, a total of 525. Generally speaking, the age breakdown, majority of them fell between the ages of 6 to 17 years old. Majority in both years were male. Majority in both years fell into the Hispanic category, and racially, predominantly, our sample was Caucasian or white. And insurance-wise, our breakdown was majority commercially insured. There were no significant differences in the basic population between either year, 2019 or 2020. All right, so again, this is taking a look at our 2019 and 2020 sample, including overlaps or duplications. We did see that in 2020 there was a significantly more patients diagnosed with anxiety spectrum illnesses, proportionally at least. Also, by percentage, more patients diagnosed with ADHD, disruptive spectrum disorder. We also see that while most medication, I'm sorry. Oh, I'm sorry. Did someone speak?
I think perhaps someone was unmuted. If everyone could just be sure to mute yourselves. Thank you.
Okay, gotcha. All right, so antidepressants were also more commonly, or more patients, I should say, were given antidepressants in 2020 than they were in 2019. But otherwise, prescription rates didn't tend to differ a whole lot between 2019 and 2020 when looking at the data this way. We also saw that polypharmacy rates did maybe slightly go up from 2019 to 2020, though this was not statistically significant. What was statistically significant was a rise, again, perhaps small, in the multi-class polypharmacy rate between 2019 and 2020. The most commonly prescribed medications included methylphenidate, guanfacine, sertraline, clonidine, fluoxetine, and 6th and 7th were risperidone and aripiprazole. The most common medication prescribed by percentage, at least, was methylphenidate in 2019, but actually this was guanfacine in 2020. In terms of the most common medication classes prescribed, again, we see ADHD medication sort of at the top of this list here. The second most common class prescribed was antidepressants, and the third was antipsychotics. Generally speaking, we didn't see that there was too large a difference in the prescription rates between 2019 and 2020. All right, and then the influence of demographic factors. So I was going to show the whole data set here, but I think it would be a little bit too much into the weeds. So I'll just generally comment that there was no observed difference in the polypharmacy or multi-class polypharmacy rates based on ethnicity, race, insurance, or gender in either 2019 or 2020 that we found to be statistically significant. The only thing that we did find, perhaps unsurprisingly, was that increased age was significantly associated with higher both polypharmacy rates and multi-class polypharmacy rates, at least until about the age of 17. So some general discussion around this. Multi-class polypharmacy and polypharmacy rates were observed to be high. You can see some of the numbers here. And a fair number of patients, 26% of patients in both 2019 and 2020 were prescribed 4 or more medications, and approximately 10% in each year were prescribed 4 or more medication classes. We We did not observe any statistically significant differences in polypharmacy rates based upon sex, ethnicity, race, or type of insurance. We did observe that older age was generally associated with higher rates of polypharmacy and multi-class polypharmacy, although that generally has been described in most of the literature that currently exists. Higher visit numbers were also associated with higher rates of polypharmacy and multi-class polypharmacy rates. And interestingly, being seen again in 2020 also predicted the likelihood of polypharmacy and multi-class polypharmacy. In other words, if you were a patient who was seen in both 2019 and 2020, as opposed to exclusively in either year, you are more likely to exhibit polypharmacy or multi-class polypharmacy. We did observe a small increase in polypharmacy rates from again, 2019 to 2020. That was not statistically significant. Interestingly, only the multi-class polypharmacy rates were statistically significant in terms of their increase. It's possible that the small rise in multi-class polypharmacy without a significant rise in the polypharmacy rates may be secondary to a high proportion of patients on antidepressants in 2020. There was also an increase in the diagnosed comorbidities from 2019 to 2020, as we discussed, which could account for some of this difference, although it's hard to make an interpretation. The most common medications used were ADHD medications and antidepressants. The proportion of patients on antidepressants increased in 2020, which corresponds with the higher rates of anxiety that we also observed. And risperidone and aripiprazole were the 6th and 7th most commonly prescribed medications in general. Antipsychotics were in general the 3rd most common class prescribed. And antipsychotics made a fairly large percentage of medications, especially when we compare them to other studies that have been done. Generally speaking, we'll talk about this a little bit later. We thought that this might have been due to our particular role as like a tertiary care center and the degree of clinical severity that we might be seeing in the Autism Center in particular. Some limitations of our study. Our definition of polypharmacy, as some of you may have been thinking, has been pretty broad, and our definition of polypharmacy was based on the annual number of prescriptions. We were unable to account for the number of days of possible overlap between medications. Samples were used from our naturalistic sample, which means basically that there was a significant amount of possible overlap between 2019 and 2020. We also did not specifically analyze our data set excluding the January and February 2020 data, which could be considered as pre-pandemic. So we thought about this and really debated back and forth a lot about what to do with this January and February data in 2020. It was a relatively small proportion of patients who were seen during that time period. Though again, just want to acknowledge that it's possible that the inclusion of the early 2020 data might have influenced our overall results. Our data was primarily based on EHR extracted data, and some medications may have been utilized for non-behavioral purposes. And we utilized an indication-based nomenclature when classifying medications. We thought this would probably more appropriately fit our clinical setting, but I just want to acknowledge that a neuroscience-based nomenclature has been more commonly used in the literature and suggested to be used. So some general conclusions. Just going to turn off my timer here. The study high rates of polypharmacy and multi-class polypharmacy rates, again with our fairly broad definition of both. Further study is needed regarding the effectiveness and safety of concurrent use of multiple psychotropic medications, especially considering our population may be more susceptible to more rates of side effects. Such research may guide a more standardized operational definition of polypharmacy and multi-class polypharmacy, and therefore prescribing habits in clinical settings. And further study should be done on the influences of demographic factors, including race and ethnicity on prescribing patterns in clinical settings. And I have a bunch of references here. Again, big thank you to both Dr. Conant and Dr. Kim, who provided mentorship through this project. And I'll pass it over to Dr. Wang.
All right.
everybody see my slides and hear me? Yeah, okay. So I'm Audrey. Those of you who don't know me, I'm a second-year fellow. I'll be talking about using the cultural formulation interview to provide culturally informed care. And a shout out to Ray Shao, who was my faculty mentor. And I'll get started. So I have no disclosures. And then, so I'll talk about a little bit about my personal interest and journey to this topic and why I think it's important. So I have some personal interest just being a minority and a child of immigrants. And then more clinically, I found myself early on in fellowship with a couple of cases that I felt like there was definitely a cultural component going on, and I felt like I could have done a better job in taking care of these patients and their families if I had better addressed these issues. And I kind of thought to myself, like, how do I go about approaching this, asking these questions? And I don't think necessarily that the standard psychiatric interview accounts for or makes space for these kinds of questions. I'll say that I think there are a lot of different ways that you could go about seeking cultural competence, but maybe because of this, it can be a daunting task. The CFI came out with DSM-5, so I thought that this would be a good place to start. And then why it's important, especially for fellows, I suppose, it's in the Acgme core competencies as well as the Psychiatry milestone project. And again, with what this whole year's grand rounds have been about is equity. And so acknowledging that structural racism is prevalent and that includes in medicine. So my goals of this project were to start an inquiry into the outline for cultural formulation and the cultural formulation interview, which I'll be abbreviating from now on because it's a mouthful, to further my own education and professional development, and in particular look into the history and development of the CFI and OFC, take a look at the DSM-5 handbook, look at evidence supporting its use, its relevance to child and adolescent psychiatry in particular, and how we might implement it into our training or curriculum. And I also wanted to be able to take the information that I learned to curate a resource to be made available to other people who might be interested in doing the same. And finally, and maybe most importantly, I just want to be able to incorporate this information into patient care, into clinical use for the future. So what I did was I went to the source. I read the DSM-5 handbook on the CFI, which is definitely worth a read if you're interested, but it's also a 300 page plus document. So what I tried to do is create a condensed outline version of that with what I felt like was the most high yield information. I watched the APA videos demonstrating CFI use, attended the 2021 Virtual Society for the Study of Psychiatry and Culture, and Dr. Zhao had the great idea of inviting Dr. Francis Liu, who's one of the leading experts in the CFI and the OFC, to speak at Grand Rounds, which was back in March. So if you haven't seen that, I would suggest going back. It's worth watching. He is a wealth of information. And then finally, I put this into practice mostly in my community clinic at ACRS, the Asian Counseling Referral Services, but also tried to implement this in all my care in clinics. So just briefly going into some background. So the DSM-4 marked the beginning of a series of efforts to systematize the application of cultural assessments into clinical practice, And so out of that was born the outline for cultural formulation. It included these 4 domains that they felt like should be included in a cultural formulation. But what they found was that there were obstacles to wider use of the OFC, mainly lack of a standardized approach to the OFC, and also they found that there was more guidance needed on what kind of clinical training and skills were needed to conduct cultural assessment. So that takes us to the DSM-5, where the CFI came out. It was created for broad use, so not only for clinicians, but also for administrators, policymakers, and advocates. The aim was to make it easier for providers to account for the influence of culture in order to enhance communication, improve outcomes. They mentioned that, it can be used in a wide range of situations, but they specifically kind of outlined a few different situations where cultural assessment may be especially relevant. Basically, when you're running into barriers that are impeding treatment. They suggested training for the CFI, including reviewing written guidelines, observing video demonstration, and then practicing intervention through case-based simulations, which is basically what I did. And then just briefly, the format of the CFI that we'll go into a little bit more, but it has 3 parts with 16 questions total in the core CFI. There are also a few other versions, including an informant version and these 12 other supplementary modules. One key part of the CFI is that it's designed to conduct the interview so that the perspective of the patient becomes at least as important as the signs and symptoms of disease identified by the clinician. In this way, the CFI can help clarify what the patient is looking for in a clinical encounter and the various possibilities for treatment. Another key principle is basically ask, don't assume, which we'll talk about a little bit more. So this is a figure demonstrating kind of the telescoping model of using the CFI. So starting with the core, and then as needed, expanding into these different topics, if needed, special populations or other informant perspective modules. So now I'll jump into the CFI itself. So basically the core CFI starts by first asking the patient about the illness, moving outward to the role of social supports and stressors, and finishing more broadly with the illness in relation to the healthcare system. Part 1 asks about the cultural definition of the problem. On the left, you can see is a guide to the interviewer outlining the purpose of the questions, and then on the right are instructions to the interview with sort of a script to reference. Part 2 is dedicated to the cultural perceptions of the cause, context, and support. And I think I want to highlight that it particularly asks patients directly about the most important aspects of his or her background or identity and avoids making assumptions about a patient, such as race or ethnicity, without accounting for their importance to the individual, him or herself. And then moving on to part 3, goes over cultural factors affecting self-coping and past help seeking. And then part 4, the last part of it is the relationship of the clinician and patient relationship, so asking directly about that. And basically making space for the patient to bring up concerns. And so I'll just briefly go over the supplementary module that's probably most applicable to us, which is school-age children and adolescents. They focus on 3 principles guiding its use. So first is brevity, that the quality of the alliance requires that, the child not be overburdened by the length of the interview. I certainly found this to be true. They also said that you shouldn't administer it as if it were a semi-structured interview with a fixed order of questioning. Rather, learn to weave in questions into your usual comprehensive assessment. And then also to take into account the developmental stage of the child. And then it has 4 sections within itself. So first, it addresses the use feelings of age appropriateness in different settings. The second section asks about age-related stressors and supports. The third section seeks to elicit expectations various people have of the child or adolescent. And then the last section addresses markers, rituals, or processes in transition to adulthood or maturity, which they note is for adolescents only. And they have a few additional questions suggested for parents. So I will move on to a case example. So I was seeing a 14-year-old Asian female with a history of PTSD, OCD, and MDD. I didn't do her initial evaluation, so I was seeing her for ongoing management while she was receiving ongoing therapy at ACRS. And we had basically reached an impasse in treatment, and where she was on like a medium, partially effective dose of fluoxetine, but didn't want to increase it or augment with anything else, which I felt like was indicated at this point. She had a lot of concern about her mother being involved in her treatment, and a lot of concern that if we made any changes, that would that her mom would make her stop taking medications completely. So I decided that this would be a good case to utilize the CFI because I felt like there were definite cultural factors at play. I wanted to make sure that diagnosis-wise and treatment course-wise, I was conceptualizing the case appropriately. And I felt like we really needed to involve her mom, but I needed to get her buy-in and her perspective first in order to do that. So here's some examples of her responses to certain questions that I pull out. But basically, utilizing the CFI allowed me to better, and I utilized the CFI informant version too, but allowed me to better understand both her and her mother's perspective, and that helped build rapport. And then in turn, as a team, kind of me as the psychiatrist, the patient, and her therapist worked together to think of ways to involve her mom in the discussion that would be acceptable to her and that would be most likely successful. So that allowed for better communication. It didn't fix the relationship or anything, but it allowed us to move forward, and got her mother to be involved and supportive behind medication changes, instead of attempting to kind of hide treatment from her mother. So pearls that I learned from this experience were that children and adolescents may have different identities than their parents depending on, their mixed parentage, adoption, or acculturation. The CFI also talks about acculturative stress, and in particular, what I experienced a lot was this bicultural identity stress, which they define as like the push-pull experience that 2 cultures can exert on the individual. And this is especially difficult and especially prevalent for adolescents and youth. The other thing I learned was to keep the interview brief and to try and weave these questions into your existing assessment rather than trying to do the whole interview all at once. And then personally, I found like the most high yield questions in my experience was First, questions 8 and 9 asking about the most important aspects of the patient's identity and how these aspects are affecting the issue. And then question 16 was another favorite of mine, which asked about the clinician-patient relationship. So challenges were just time constraints, which is always a challenge, and the wording of some of the questions could be repetitive, but I think you could just kind of find your own way to word those questions. How people might use this in the future. So again, integrating the CFI into your existing interview, but I think this requires being familiar with the content of the CFI and the supplementary modules. More specifically for the fellows in the program, I think we get lectures on cultural competence, but it's always hard to make that jump from like didactic lectures to actual practice. So I think having all fellows kind of have the experience of conducting the CFI and writing a cultural formulation would be especially valuable. And that is the end. Thank you all for listening. Stop sharing.
So that's our group of presenters today. I want to congratulate and thank each one of you for your terrific presentations. You can see that this just illustrates the breadth of our program and the wide range of topics and interests that each of our fellows has. And each one of them is, I think, uniquely relevant to our academic and clinical mission. I think you can also appreciate that each one of these presentations could constitute a grand rounds in and of itself. And their ability to condense and present this is really a remarkable accomplishment. These scholarly inquiry projects afford an opportunity for fellows to develop their own interests and follow their own passions. It also provides an opportunity to work closely, potentially, with faculty in a way that's distinct from our usual supervisory model. I do want to particularly call out kudos to Carrie Williams, who acts as a staff coordinator for this and has done just a terrific job of keeping me on track and keeping the group of fellows on track, and also to call out to Doug Russell, who serves as a co-coordinator of this activity for the fellows. Again, we hope and intend this to be a tradition on an ongoing basis for fellows to showcase their work to a broader audience. Be interesting to hear the audience's responses to this. Mindy's collating any questions that there might be, and if there are others, please do send them via the chat to her. I personally think that this is one of the best things that we provide in the training program. It allows a fellow to define themselves and to work on something that they're truly interested in. And again, I'm really pleased to have been part of this for many years, and it's a tradition as well as a training requirement, which I trust will continue. So thank you all. And if there are questions, Mindy, you can field them or recite them to the group. Thanks, everybody.
Excellent. Yeah, thank you for those concluding remarks. And I think to your point about, wondering what the community thinks, I think if you look in the chat, I hope all of our presenters have looked to see all of the comments that are coming in. There are a couple questions, but there are many, many, many comments about the nature of the work, the positive impact that these projects are having, the importance of the work, et cetera. So I hope you guys all take the time to look through the comments that were made about your presentations, because I couldn't agree more about the value. I also noticed that our attendance was, I think an indication of how the community valued these presentations. We were up around 150 for the majority of the time, and even after 2 hours, we're still well above 100. So that is a really, really nice indication of the value that people were seeing here. So we do just have a couple minutes. We're trying to wrap up by 9:55 because we have faculty meeting at 10, and I'm sure other people have meetings at 10, and we've been on for a couple hours here. But I do, I will ask one question. We only just had a couple, but Dr. McNulty, Doug Russell had a question for you, which I thought other people might be interested in as well. He says, great presentation, important and cutting edge topic. Curious to hear your thoughts about the relative contribution of prenatal exposure to inflammatory cytokines versus postnatal exposure. So that was an interesting question that came in that I thought you might make a quick comment on. Oh, and we don't have your sound again. Oh dear. Nope. I think I can see you saying, there we go. We've got you.
You can hear me?
Yep.
Okay. That's so weird. So yeah, actually, it's a good question. It's the reason why I didn't include it in today's presentation is it's a vast topic that's probably in need of a review paper of its own. But I will say that there are hundreds of papers dedicated to this topic. Most of them are in animal models, but the majority of them do point to a great deal of influence in the prenatal environment, particularly with IL-6 and tumor necrosis factor beta and bone density, BDNF, bone density, something I can't remember. But those are the three that come to mind that are like the biggest contributors, and it makes sense because they're all involved in neurogenesis. So a lot of these studies look at increased inflammation due to maternal stress, and then the risk of development of psychopathology in longitudinal cohort populations. And the basic answer is yes, it's a huge contributor.
Very, very thorough answer packed into like about 60 seconds there. Thank you. We did also have a question for you, Evan, but I'm gonna, it was from Larry. So I'm gonna encourage you guys to maybe chat about that offline. If Larry's interested in following up with you about that, just in the interest of time, I wanna be respectful of giving people a couple minutes here. But again, thank you to everyone who came. Thank you to our amazing fellows. More comments are coming in the chat about how much everyone has appreciated these presentations. So we can't say enough about how great everyone did this morning. Thank you everyone for coming.
Thanks all. Take care.
Thanks. Carrie, should the fellows stay on this link or log off and log on to a different one later?
Yes, thank you, Carol.
They have their own separate link for case conference.
Okay, so we'll end this one. Thanks, everybody.
And case conference will be at 11.
Correct.
Yeah, okay, great, thank you.
Is Gabrielle still here? We could forward her the question from Dr. Wade.
I can, let me cut and paste it and I can send it to her.
Great. Dr. Wade, do you want to put your email in? So if we want to connect her, I see you're still here, but she's not.
Hi, yes, I can put my email in. I just want to clarify that I'm not a doctor.
Oh, okay. Avery
Yeah,
then.
sorry, thank.
Yeah, no problem. Sorry for misidentifying you.
Yeah, I'm happy to send that along to her.
Great.
Okay,
Thank you.
perfect.
Thanks to Del and Carrie too. This worked out. And Mendy, as usual, you're great with the questions, even though there wasn't much time.
Yeah, we were, and I forgot to make my announcements, but you know.
Me too. So
yeah.
Things to strive for next year.
Right.
Del, did you have something?
No, I was just saying it all worked out. So it was really great. So
yeah, it was an
great job.
Set of talks.
Absolutely.
All right. Thank you.
All right. Good day, everyone.